the Philippines, and good morning, good afternoon from wherever you are. It's a privilege for us to have this webinar once again, and this time we will be presenting a lecture by Dr. Jeimylo de Castro, our man of the hour, who's also in space watching over us. Good evening, Dr. Jim.
Good evening. Yes, good evening.
Okay, but before we start our lecture, just as our tradition is, we'll have a prayer. Is it okay with you, Dr. Jim?
Yes, go ahead.
Okay, let's put ourselves in the divine, uh, presence of the Lord. Dear Lord God, we praise you and give you thanks for this day. Please bless our speaker this evening, Dr. Jim, that he may be able to impart to us the lessons that you wish for us to know. And at the same time, please bless all the attendees today and those who will be watching from wherever they are. Please keep us all safe and please help us to be open so that we may be able to understand the generous lessons that you have imparted and you will be imparting to us so that we may help our patients through your healing hand. All these we ask in your name, in Jesus' name, amen. Okay, so good evening, everyone. And again, hello for all those who are attending today. Today, speaking for us is the man who has made this all possible, and he needs no much further introduction, although I am to say that we're so proud because he will also soon be coming up with his book. And you're going to be the editor, right, Dr. J, for another book upcoming. We're so excited for this. It's another chapter of your professional life and we will surely be purchasing the book that you will be editing. So before this all comes out in the pages, we want to listen to your lecture this evening. Good evening, Dr. Jeimylo de Castro.
Yes, good evening. Can you hear me?
Yes, Dr. Jim, and we can see your slides. Anytime you're ready, we're ready.
Okay, can you hear me? Can you see my slides?
Yes, Dr. Jim, we can see your slides. Okay, the floor is yours, Dr. Jim.
Okay, good evening, everyone. Is the voice heard, audible?
Yes, you had the concert again last night.
Okay, okay. Anyway, I'm gonna share with you our lecture on the approach to clinical ultrasound of the lower extremity nerves. Maybe some of you have seen this because I've shown this several times to other groups, and this could just be a repeat to some of you, but hopefully you can appreciate it back again. So I added some very important areas by which we can also add in our study tonight. So this ultrasound study on the nerves is a very important part of our diagnostic capability and ultrasound because there are just a lot of details that we can see here as I combine them both with ultrasound and some kind of pictures that I think would be also appropriate for your use in your practice. So let me just start it with a verse that I always share with everybody in Isaiah 40:29-31. It says, God gives power to the weak, and to those who have no might, he increases strength. So if you are someone who is weak and who needs strength, God is telling you that he is giving that to you for free. Because even the youth shall faint and be weary, and the young man shall utterly fall. But those who wait on the Lord shall renew their strength. They shall mount up with wings as eagles. They shall run and not faint. So this is the outline that I'm gonna share with you tonight. We will divide it into three regions. We have the hip, the knee, and the ankle. And as you can see here, there's just a lot of nerves that we will have to cover in the hip, in the knee, and in the ankle. Some might be new to you in terms of the nomenclature, but I'm sure you know them. It's just that the terms are very much different. So we will try to discuss them one by one. And at the end of the lecture, if you have any question or addition, then you just feel free to add it up in a chat or verbally. So this is what you call the lumbosacral plexus. And as you can see here, the lumbosacral plexus is actually divided into two parts. We have the thoracolumbar, I would say part of the T12 and most of the lumbar fifth also makes up another plexus, and another one, which is on the right, is formed by a combination of the distal portion of L4, L5, and S1, S2, and S3. So if you will look at them, it's much different from what we see in the brachial plexus, where they are very much organized. Here, it enters and exits from different levels. So as you can see here, let's say in the T12 and L1, you have your hypogastric and your ilioinguinal nerve, which is primarily L1, but it could be contributed by T12 if it is a prefixed, or if you have genitofemoral, it's L1 and L2. And then we have smaller branches like your lumbinguinal branch. And then of course your external is spermatic branch. And then we have your lateral femoral cutaneous nerve, which is a sensory nerve coming from L2 and L3. And we have your femoral nerve. The bigger portion of that is L2, L3, and L4. And then the smaller version of that is obturator nerve, also from L2, L3, and of course L4. Sorry. Then of course on the other side, on the right, then we have L4, L5, and then S1 is to S3. Then what you see here is, of course, the common peroneal nerve and tibial nerve that forms your sciatic nerve. Now, let me say this note here early on. As you can see, the sciatic nerve is a combination of these two nerves. But from the very beginning in fetal life, their origin is always distinct, although they are together in terms of the nerve called sciatic nerve. If you try to dissect them, they are actually two distinct nerves. So you can actually hydrodissect and choose which ones you would like to block or hydrodissect, because they can be separated from the very origin of that nerve. In other words, as it reaches the knee, where they actually could be obviously seen to be separated into posterior tibial nerve and common peroneal nerve, originally from the more proximal parts, they are already distinct nerves from the very beginning. So that's just what we would like to highlight here. And then of course, we would start from the more proximal portion of the lumbosacral plexus, which are made up of three different nerves. And you call this as your long collateral branches of the lumbar plexus. You have your iliohypogastric coming from T12L1. You have your ilioinguinal, which is purely L1. You have your genitofemoral nerve, which is coming from L1 and L2. Now, it is very interesting that all these nerves actually arises above your inguinal ligament. And it divides into your external spermatic branch, if it is a genitofemoral. And then, of course, you have your lumbinguinal branch, which is also called the femoral or crural branch. Eventually, you will realize later that they could actually be divided into either lateral or medial, because there's just a lot of variations that we see along the way. So here is, for example, the genitofemoral nerve right here. Okay, you can see it perforating just underneath your inguinal ligament. Then, of course, the nerves right above it are the ones that comes from your iliohypogastric and your ilioinguinal nerve. And then, as you can see here in the drawing, all of them actually arises from L1 and L2, or partly T12, depending if it is prefix or postfix. And then they kind of move around the muscle layers between your external oblique and internal oblique and transversus abdominis. And then, of course, they winds around the abdomen, and as you can see, it appears anteriorly that the ilioinguinal is more lateral and the iliohypogastric is more medial. But actually, if you look at how it winds around, you will notice that the iliohypogastric is actually more lateral and the ilioinguinal is more medial. So anyway, that's just how it's being represented. And if you look at this, you will notice that it goes around, and part of the innervation could also go to the proximal lateral portion of the hip, and then goes all the way to the front. And then part of these nerves could be entrapped anywhere in this area, although we will discuss that also as we go along on the entrapment areas. And then, of course, you see the genitofemoral nerve. And if you look at the genitofemoral nerve, they divide into either your genital, which is going to the sacrum, so they say the scrotum, and then for females, for the labia majora, and then, of course, the femoral branch, which is very close actually to the femoral nerve, is the one that innervates just at the proximal anterior thigh region. So this is very close. So sometimes it's very hard to distinguish them unless you know exactly where to locate them and suspect to where it's really affecting the patient. But as we go along, you will learn that there's just a lot of ways to distinctly identify each of these branches of the nerves. So right here, for example, in this table, you will notice that the iliohypogastric, ilioinguinal, and the genitofemoral nerve are all mixed nerve. In other words, they have both sensory and motor. And you can see here that it innervates abdominal muscles, but at the same time, it also gives branches to what we call the anterior cutaneous nerves that is found right in the middle, that could also be entrapped and cause pain at the mid portion of the abdomen. Now, interestingly, the genitofemoral nerve is the one that goes to the cremaster and, of course, part of the abdominal muscles as well. And then it innervates, interestingly, the scrotum and the labia majora. We will have to emphasize this part because this seems to be a very important identification part here, because a lot of times we thought the scrotum and labia majora are innervated by the pudendal nerve, but actually they're innervated by the genitofemoral nerve. Eventually, we'll also realize later on that there is another nerve that innervates this part as well, and we will go to that as we go along the lecture. And then, of course, the lateral femoral cutaneous nerve, which is an L2, L3, is a pure sensory that innervates of the lateral thigh. So how do we locate their location in the abdomen? So you look at these three layers. You have your external oblique, you have your internal oblique, and you have your transversus abdominis right here. And so where do you look for them? You will look for them between your internal oblique and your transversus abdominis layer. So the fascia in between those two muscles is where those two nerves is located, the iliohypogastric and the ilioinguinal. And usually the ilioinguinal is more lateral in this location and the iliohypogastric is more medial. Now, sometimes depending on what ultrasound you're using, it could be very difficult to locate which ones are the nerves because of their very tiny structure. So if you aren't sure about that, all you have to do is just to look at the fascia layer and suspect that that is where the nerves are located. You really don't need to go into so much detail if you're using just the regular kind of ultrasound. But if you're using a high frequency ultrasound, then you can see all the details and it can point to you which ones really is the ilioinguinal and which ones is your iliohypogastric. Now, MRI can also show that as well. And here, these are very tiny structures. And so just to point out that even though the ultrasound is a very good modality for diagnosis, the MRI can do that as well, but not as distinct as the one that we see, of course, in the ultrasound, especially if you're using a high frequency ultrasound. Now let's go to your genitofemoral nerve. So these nerves, as we have mentioned earlier, arises from the ventral rami of S1 and S2. And we have also described where it originates and then where it divides into a genital and, of course, the femoral branch. And then, of course, what is interesting here is that, as I mentioned earlier, it innervates the scrotum and labia majora, as I mentioned earlier, especially the area of the anterior portion of the nerve. the femoral part is actually very close to the femoral nerve, the bigger femoral nerve. Okay, and it is also crossing the deep circumflex artery, which passes deep into the inguinal ligament. And then, of course, it moves from lateral to the femoral artery. So if you have the femoral artery very distinct, so as you can see, more lateral is femoral nerve, next to that is femoral artery, and next to that is the femoral vein. So you can see that the femoral branch, the genitofemoral, is actually located between your femoral nerve and your femoral artery. So you can look at this. I will show it to you later on. Now, the other thing is, this study by Iwanaga mentions that, as I mentioned earlier, the femoral could be medial or the femoral could be lateral, depending on the distribution, because there, as I've said, there are just a lot of variations. But supposing, let's say, we're talking about the medial, in about 21%, the medial could be femoral, and the lateral could be genital in about 17%. So that's what this was saying. That's why some anatomists would say and would suggest that maybe instead of using genital and femoral nerve branch, they would just say medial and lateral branch, just not to add confusion to the already complicated structure. So that's it. And of course, here, as you can see here in their cadaver dissection, this is your lateral branch. This is your medial branch right here. But as you can see, there's just a lot of other smaller branches that comes after it. And here's another one at the proximal portion. This is the lateral branch. You can see here, and there's just a lot of other branches that goes after it. And then, of course, you can see the medial branch going this way into your scrotum and labia majori for the females. And depending on the ratio of how many branches does the medial have compared to the lateral branch. So here you can see the graph pointing to so many branches. For example, in the lateral branch, you have at least 5. Then in the medial branch, there's about maybe 3, okay, or just 2, okay? And this is another illustration of how different these branches are coming from their origin into the distal portion. So assuming that this is your inguinal ligament right here, so it either could split before it actually reaches the inguinal ligament, or some branches could split right after that. So it really depends. So as I mentioned earlier, authors like Dr. Iwanaga and his colleagues would say that it doesn't matter where it originates. It all depends upon whether it's located medial or lateral, just to be able to locate those branches. Because sometimes, according to him, if we say medial branch and we found out that the medial branch is actually located in the lateral, then it gives more confusion in the process. So this is a very small nerve. Hardly can you see it on a regular ultrasound, but we made some effort to make sure that we can see it, although it's really small. And in a regular ultrasound, sometimes you shouldn't see anything at all. So those are the genitofemoral nerve and those 3 branches that are very small. Now let's go to the hip region. Now let's begin with your femoral nerve. So the femoral nerve in the anterior hip is coming from the posterior divisions and ventral rami of L2, L3, and L4. And sometimes, as I mentioned, if it is prefixed, it could be L1, or postfixed, it could be L5. And it is coming also in a very tight fascia between the psoas and iliacus if you talk about the posterior portion where it arises. But surprisingly, entrapment doesn't happen in that area in spite of its very tight location. And usually it takes an external impingement for it to happen. For example, it is compressed in this level if there is a hematoma. So if there's bleeding, you suspect it to be compressed. So anything that could affect the femoral nerve could be actually due to a hematoma right on the posterior portion of the retroperitoneal portion of the of the lumbar. So it could be at the inguinal ligament, it could be at the lumbar roots, or it could be a space between your psoas and iliacus. So any of those areas could be a site of entrapment for femoral nerve. But the critical zone of entrapment is actually at the inguinal ligament, which is actually, if you look at it and scan it, it's deep to your iliopsoas and of course the iliopectineal band. So that's what is considered to be the critical zone of entrapment for your femoral nerve. So very easily we can identify it because we have the femoral vein more medially, femoral artery here, and then of course the femoral nerve more laterally. And this is a little proximal. And then as we move a little distal and medially, then we can see that there are other muscles that comes out like your pectineus and of course your psoas tendon and your medial and lateral iliacus. Also, you can see all of them. So this is how you can view also the femoral nerve in ultrasound. And as you can see here, as we've already illustrated, after the nerve has exited the inguinal ligament, as they punctured through it or underneath it, it actually divides into several smaller branches distally, as you can see it. There are a lot of small fibers in it. And so it is very important to realize that immediately after that nerve exits into the inguinal ligament, the nerve just dispersed into very, very small branches. And that gives Dr. Short and his colleagues the identification of whether you're dealing with the high femoral nerve or what we call the low femoral nerve in terms of its location. So here, for example, if you look at the green part, this is your high femoral nerve location. And then as you can see the blue part here, this is the low femoral nerve location. Actually, they have already dispersed in this area. This is very essential for anesthesiologists because they use it to identify their approach and of course their injection when they do a block. Now some other details are found here. So like in this case, we have your obturator nerve, a high obturator nerve and low obturator nerve, although we'll discuss that a little later. But at least in this case, we can also see a high and low obturator nerve, something like we see in femoral nerve. This is also an illustration of the high and low obturator nerve. So with that, we would also want to know how these nerves will innervate also the hip. There's always a lot of interest as to the innervation of the hip because for some of us, especially those of you who are doing prolotherapy or neural prolotherapy, you would like to know exactly what nerves goes into the hip that you can actually block so that you can completely denervate them, either dissect them, and then if there is any pain in the hip, that could at least relieve the patient of the pain. So here we go to two nerves first, anteriorly. So we have two articular branches to the hip joint. We have your femoral nerve in about 95% of cases. It innervates your anteromedial and of course the anterolateral part of the hip joint capsule. So that is very interesting because if this is your hip joint capsule location, then all you have to do is to just inject or hard dissect this femoral nerve right here, and then you actually remove the pain right at those two areas, anteromedial and anterolateral part of hip joint capsule. At the obturator nerve portion, this innervates 85% of the hip. So we have your anterior and we have your posterior branches. And we know that the anterior obturator nerve is between your adductor longus and brevis, and the posterior obturator nerve is between your adductor brevis and magnus. And this one, interestingly, innervates the inferior anteromedial aspect of the hip. So if there is any pain on that area below the inguinal part, inferior and anteromedial, then we can actually hydrodissect the obturator nerve. And by just locating where it is located, then we can actually remove the pain 85% of the time. The other thing is that, as you can see this graph right here, it could actually vary whether you're dealing with an obturator high, obturator low, or femoral high, or femoral low, depending on what type of anatomic location you're dealing with. So right there, for example, if you're dealing with a femoral high, for example, in superolateral, it has 9/13 of the location, and the superior medial, it's about 8/13, but it could also innervate 8/30 of the inferolateral, and of course your inferomedial. But if you are having a femoral low, look at that. What happened is that you don't quite remove the pain if it is painful, because the location, depending on its location here, will only affect one of the 13 location of that particular nerve that innervates the hip joint. Of course, it holds true with the obturator nerve. Look at this. In obturator high, for example, the inferomedial will affect 7/13 of the time. But if it is an obturator low, then it wouldn't actually affect much. So that is the importance of knowing whether we're dealing with a femoral high or obturator high or low femoral and low obturator. So this is the location by which we can actually try to kind of hydrodissect. So these are sites like, for example, the C and D. This is where you need to highlight and scan your structures and your nerves. And then the E and the F is also where you need to see all the other details of the structures, especially in relation to the nerves. So just guiding each one of you how you can scan all this. And then of course here, it is also important if you're dealing with a younger patient and an older patient, because what happens here is that if you are dealing with a younger patient, usually the sheath are very taut. In other words, they kind of crowd in one single area. You can see all of that. But sometimes for older patient, you might lose track of where is the femoral nerve. It kind of separates from the femoral artery and the femoral vein, because look at this. It actually moves more laterally. So depending on the age, again, you just have to be conscious that sometimes you won't be able to see the femoral nerve quite as clearly as the rest of the structures. So the age would also matter. So this is just an illustration. This is a study made by Yoshimura of the young patient. Look at these nerves very close to the femoral artery, and look at this when they are so far from each other. So just to give that distinction as well. How about the posterior hip? So the anterior hip, we have the femoral nerve and obturator nerve. What about the posterior hip? So some of you knows this already, that the posterior hip actually is innervated by your superior gluteal nerve that innervates the posterolateral portion of the hip. And of course, the other one comes from your sciatic nerve. This is the nerve from quadratus femoris. You can go directly to the sciatic nerve. You can go directly from the superior gluteal nerve. And the superior gluteal nerve is located between your gluteus max and your gluteus medius when you scan it. So just gonna show you here. This is your superior gluteal nerve. This is gluteus max. This is your gluteus medius right here. And your superior gluteal nerve is right in between. So if you're gonna attempt to actually hydrodissect this part posteriorly, then you can go all the way here. This is about 5 centimeters deep. So you have to use maybe a 3-inch needle to be able to reach the target. So in summary, the hip joint innervation is made up, of course, anteriorly we have your obturator and femoral nerve. That's easy to remember. And posteriorly we have your sciatic and you have your superior gluteal nerve. So those are the four nerves that primarily innervate the hip joint. Now let's go to your sciatic nerve. Now early on, we had mentioned that the sciatic nerve is composed of your posterior tibial nerve and common peroneal nerve, and they are actually distinct from the very roots. In other words, they could be called sciatic nerve because of their, uh, as they are joined together, but actually they are distinct structures from each other. So they are separate entities even during the embryological stage. So the anterior division of ventral rami is your posterior tibial nerve. The posterior divisions of the ventral rami are your common peroneal nerve. And they innervate the posterior compartments of the thigh and also of the leg. And we know it exists at the greater sciatic foramen, as you can see here in the illustration. But don't you know that they also have a lot of variations? What we classically know is this one here where you have the piriformis muscle, and right underneath that we have your sciatic nerve. They all comes from your greater trochanter, it goes all the way to your sacrum. And then of course you have other external rotators. You have your superior gemellus, obturator internus, inferior gemellus. We have your quadratus femoris on this area here. So as you can see, it could also be varied, like here in these two illustrations. It could be split, and the split could happen in the middle of the piriformis muscle. It could also be split this way. So there's just a lot of illustrations. Now let me just show you here the different variations of your sciatic nerve. I'm sure some of you would like to measure the circumference, the cross-sectional area as well. So Chen et al. In 2018 made a study, and just to give a rough estimate of how big the sciatic nerve is, he measured it, it's about 0.527 plus and minus 0.028. So it's almost like 5 times bigger than your median nerve at the wrist, okay? So that's how you can imagine that. But as it approaches the knee at the popliteal fossa, it's still big. It's 0.44 centimeters. So, but of course, the best way to actually see any abnormality is to compare it right and left to be able to see if there's any difference. It could be bigger than that, especially when there is any compression or entrapment of that particular nerve. So this is another illustration of that, how it varies. And for all of its complications, piriformis syndrome, which is pain in the buttocks attributed to an impingement of the sciatic nerve, is only about 6 to 8%. So there's not a lot of that actually. So when we actually complain of pain on that gluteal area, we always say, oh, it's piriformis syndrome. But remember, it is only 6 to 8%. And I will show you later on that there's another issue here other than the piriformis syndrome, and this is your deep gluteal syndrome or entrapment. And this is another issue that we found in these muscles in the buttocks, because we always encounter this a lot of times. Patient would, when they come to us, they always complain of pain on the buttocks. And if it is below the iliac crest, we say, oh, it could be a piriformis, could be some kind of a nerve entrapment. And the patient would say, oh, it goes all the way to the legs. It could also be a deep gluteal syndrome, which is actually an impingement of the sciatic nerve just underneath or between your gluteus maximus and your quadratus femoris muscle. So this is another entity, and it is described as a very deep pain. The pain is deep. It's not like the pain right at your upper portion of your buttocks, maybe the upper half, but it is at the lower half, and it is very deep. So consider that, and the entrapment is actually between your quadratus femoris and your gluteus max. So that is very interesting also to find. And so this is how you can actually sonographically illustrate it. You go to the area of your gluteus quadratus femoris. This is your gluteus max. This is your quadratus femoris. This is your sciatic nerve. And so the deep gluteal pain that the patient is feeling might be right here. So this is one finding that you can also check and then see for yourself that maybe while you are trying to dissect it at a higher level, then you have to go down right at the quadratus femoris area because the sciatic nerve could be entrapped right there. Now, another interesting finding here is that we sometimes talk about the peroneal branches, and we don't realize there are actually two peroneal branches. The first one is a branch of your sciatic nerve. The other branch is the branch of posterior femoral cutaneous nerve. And if you look at this illustration here, the one on top is the branch of the sciatic nerve, but the one below it, which is actually very close to the sciatic nerve, is your posterior femoral cutaneous nerve. It has its own branch, which is also your posterior, which is coming from your posterior femoral cutaneous nerve. So in other words, if we say peroneal branch, we have to ask which origin. Are we talking about the sciatic nerve origin, or are we talking about the peroneal or posterior femoral cutaneous nerve origin? So that we have to clarify. So if it is from the sciatic nerve, so it is contributed in about 33%. Okay, that also would have, should I say, the peroneal branch of the posterior femoral cutaneous is 32% coming from the PFC, and the 67% comes from your sciatic nerve. So it's still majority of it would still come from the sciatic nerve, but 33% would come from the peroneal branch by the posterior femoral cutaneous nerve. So here, the posterior femoral cutaneous branch is actually coming from your S1, S2, and also the ventral branches from S2, S3. And it is the one that gives off branches to your inferior cluneal nerve. So I'm sure you know the inferior cluneal nerve just at the edge of your gluteus max. You can see there is a nerve that goes all the way up. That is your inferior cluneal nerve. The origin of that nerve is your posterior femoral cutaneous. So in other words, it has two branches. The PFC has two branches. It has the peroneal branch, and it has the inferior cluneal nerve branch. Okay, so this is 4 centimeters inferior to your ischial tuberosity. So here, this is the location of your sciatic nerve and the location of your posterior femoral cutaneous nerve. So they are all almost close to each other. Look at this. Sciatic nerve here, medially, posterior femoral cutaneous nerve here. So you can actually see them side by side to each other. Now let's go to the posterior femoral cutaneous. So as you mentioned earlier, it has its inferior cluneal nerve that goes into the lateral, anal, and scrotolabial areas. And then it has a peroneal branch that goes into the lateral, anal, scrotal, or labial skin. So initially at the beginning of the lecture, you notice that the genitofemoral branch has a branch that goes into your labia majora, and then of course at the scrotum anteriorly, but posteriorly it is also contributed by the peroneal branch coming from your posterior femoral cutaneous nerve. So the key here is that if the patient complains of pain at the scrotal area, at the labia majora, then we have two nerves that we have to think about: the genitofemoral and the posterior femoral cutaneous nerve, but not the pudendal nerve. Not the pudendal nerve. So other innervation is, it also innervates the posterior surface of the thigh, infragluteal fold, skin over the ischial tuberosity, and then of course, as mentioned, the scrotum and labia majora. So this is always, as mentioned, misinterpreted to be also innervated by the pudendal nerve, but it's not. So here is the area being innervated by those nerves. So this area here at the buttocks is innervated by inferior cluneal nerve. So you can actually spot this area and check this. This is right at the ischium. And this one here is your peroneal branch. Look at this. And this one at the center here is your pudendal nerve. So you can see here the different area of distribution of all these nerves. So where is the entrapment of the posterior femoral cutaneous nerve? So usually they attribute it to the lateral fibrous expansion, which is at the medial side right here. This is where the entrapment site usually happens. So it's very close to your ischial tuberosity. So as you scan and locate this nerve, your reference could be your ischial tuberosity, and just beside that will be your posterior femoral cutaneous nerve. So it is at the medial side, beside the lateral part of the ischial tuberosity, in a sitting position. So the pain is more lateral as compared to the pudendal, which is more medial. But of course, the pudendal nerve will not innervate, of course, as we mentioned, the labia majora, the scrotum, but this one will also not involve the clitoris, the penis, or the anus. So this area, as mentioned, is the one that is being innervated by your pudendal nerve. The clitoris, the penis, the anus are all innervated by the pudendal nerve. Okay, so again, another illustration here of the posterior femoral cutaneous nerve. Posterior femoral cutaneous nerve, this is your ischial tuberosity. So you can see here, very medial. You can see it right here. Okay, in spite of all this classic illustration of these nerves, there are just a lot of variations as well. So you can see here, coming from the origin, this is your posterior femoral cutaneous, then it splits into different ways as inferior cluneal nerve. So just for your information that they can vary a lot of times because of a lot of their variations. So as I mentioned earlier, this is your gluteus max. And at the edge of that, look at this. This is your posterior femoral cutaneous nerve. Okay, then this is your inferior cluneal nerve. Of course, this split just underneath this area. And then, of course, over this area would be the peroneal branch. So this is your peroneal branch going this way. This one is your posterior femoral cutaneous. So if you put your probe in this location, you can see all these nerves, but these are very tiny nerves. You cannot see them using a regular ultrasound maybe, but if you're using a high frequency ultrasound, you might be able to see them. Now let's go here to your pudendal nerve. So pudendal nerve is a mixed somatic and autonomic nerve from S2 to S4. It innervates the pelvic floor muscles, external urethra, sphincters, and pelvic organs. And these are the 4 areas of entrapment. But just remember the first one at the Alcox canal. I will show you later on where that is. Then, of course, it could be also entrapped here in 13%, ischial spine at 4.8, sciatic nuts at 2.1. But most of the time, the entrapment happens here. So pain in the penis for male, pain in the clitoris for female is where the pudendal nerve is, but no pain on the labia majora, and of course, no pain in your scrotum if you are talking with pudendal nerves. So here is how to locate that. So let's say this is your ischium right here. So this is a transverse view of the ischium. Then you will notice that at the edge of this ischium is a rather pointed edge here. And then you can see here the pudendal nerve. It is very close to an artery and a vein. So for you to visualize it better, you can probably use your color Doppler to be able to see that this pointed thing actually points directly to your pudendal nerve. That is when you would like to block it posteriorly, and that is where your pudendal nerve is located. Now, the Alcox canal, if you will notice here, is that if this is your pudendal nerve right here, there's a very narrow space on this area right in between your ischium, and then of course at the sacrotuberous ligament, and this is what you call your Alcox canal, and this is where the entrapment happens. So if there is anything that could be hydrodissected, then you just have to go to this area. And if I have to go back to the slide, it would be somewhere here on this area right here where the entrapment really happens. So if you're looking at this area here, this is not just entrap, but right here. There are also a lot of variations in spite of the fact that we can classically identify the pudendal nerve as we have illustrated, but these are just some of its variations that we need to consider when we're looking at and considering its location. So pudendal neuralgia, it's represented by about 4% of patients with chronic pain at the area that we had mentioned. And since it also innervates the sphincters, there are signs that points to that: the urinary frequency, urgency, painful bladder syndrome, peroneal pain, and dyspareunia. So all of this is because of the fact that it innervates the sphincters. So if patients would complain of this, you are dealing with the pudendal nerve. But otherwise, you're dealing with the peroneal branch of either the sciatic or the posterior femoral cutaneous, and then anteriorly, the genitofemoral nerve. So this is one way of differentiating that. And of course, it affects sitting and sexual activity. That's pudendal neuralgia. So compression or entrapment occurs between the sacrospinous and, as I mentioned, at the sacrotuberous ligaments or inside the Alcox canal. So as you can see, the sacrospinous is the ligament that goes into the spine of the ischium and goes to the sacrum. And the other one is a more vertical one of the sacrotuberous ligaments. And this is what forms your Alcox canal. So that is how you can locate all this in between these areas. So this is the exact location of the entrapment site if you are doing and trying to look at this. Okay, then let's go to your lateral femoral cutaneous nerve. This is from L to L3. It's a pure sensory. And of course, the normal size is about 1 to 2 millimeters squared. Anything that is more than 5 millimeter is considered abnormal. So we quite know this particular nerve. It's between your tensor fascia lata and sartorius, just below your anterior superior iliac spine. You can find this nerve right here. But there are a lot of variations as well. Look at this. It could go this way classically, but it can also go above it, or it could split, or it could go above the axis. So there's a lot of variations that you have to see for lateral femoral cutaneous nerve. And this is described to be a flat-filled flat tunnel. And of course, this is 10 centimeter distal to the axis. And of course, there is also a posterior branch in about 11%, about 18%. So this is just the variations. Now, as you can see here, these are just how they course through those areas. So much different patterns of the lateral femoral cutaneous nerve. So we know that if it is entrapped, we call this the neuralgia peristhetica. So it's also about 6.7% to 35%. So what is the cause? It could be the inguinal ligament happening during pregnancy or obesity, or it could be because of the tight clothing or limb length discrepancy. So it could happen like that. Now, Lee made a study as to who is susceptible to having a lateral femoral cutaneous nerve. And so if you look at the distance, if your femoral nerve is very close to the anterior superior iliac spine, there is a greater tendency for you to have an entrapment. So less than 2 centimeters. Whereas if you have greater distance, look at this for instance, the distance is very much far from where it is, then the chance of you being entrapped would be less. So it might be worth, when you do your scanning, to kind of measure the distance of the lateral femoral cutaneous nerve from the axis and try to induce from that findings whether you are dealing with a nerve that could have a higher tendency to develop entrapment or not. So you can divide this into 4 parts, as you can see here. So in about 67% of the time, it is very close. In fact, about less than 2 centimeters. So, but in about 13.9 to about 9.7, it could be far from it. So you might be included in this kind of location. So you have a lot of tendency to develop lateral femoral cutaneous nerve entrapment. So what is the sensation is burning, tingling, or sometimes numbness. So you can just do hydrodissection, and then there are studies using steroids, of course, 5% dextrose or PRP, whatever you use, it's okay. And then of course, these are findings that you can find when you have neuroma formation in those nerves that is being affected. And interestingly, they did an ultrasound EMG placement, and guess what? They can get a higher sensory amplitude in areas where they put the exact location of the lateral femoral cutaneous nerve where it is supposed to be located, rather than just guessing it where it should be. So maybe for those of you who are doing EMG, you can use an ultrasound guided EMG to be able to also do that. Let's go to your obturator nerve. So obturator nerve is the ventral rami of L2, L3, L4, L3 being the largest branch. It divides into your anterior and posterior, you know that already. And the anterior portion is the one that goes into the hip joint, and the posterior is the one that goes into the knee joint. So just for you to know, anterior, hip joint, posterior, knee joint. Okay, so if you are going to be more specific, which one do you want to hydrodissect? Anterior, posterior? Depends what area you would like to treat. Anterior, hip, or knee. Anterior, hip, posterior, knee. And then of course, it is located beneath the pectineus muscle. Okay, and of course, obturator neuropathy could be caused by pressure or injury to the obturator nerve at the upper part of the obturator foramen. It could be a pain or loss of sensation over the upper medial thigh. So upper medial thigh, it's almost the opposite of your lateral femoral cutaneous nerve, with or without hip adduction weakness. There could be a hip adduction weakness, or there could be none. These are different sites of injection. So you can do between your pectineus and of course your external obturator externus, I should say, or it could be under your pectineus if you are going to do it at the main branch. So right here, for example, this is your pectineus, this is your obturator nerve, this is your obturator externus. Then if you go distally, then these are the layers. Ductor longus, brevis, magnus, anterior obturator nerve, this is posterior obturator nerve. So it really depends where you would like to hit them. More proximally, you get the entire nerve, or if you have a branch nerve already, you can just go lower than that. Then of course, this is another illustration of that. Then of course, you can also, for those of you who are doing a lot of blocks, you can block both anterior and posterior. And this is between your pectineus. I have illustrated an obturator externus, so very, very proximal. So you have to go like this. I don't know if you would dare do this to your patient, but you have to ask permission if they would allow. Then of course, these are just variations of how they go all the way down to your knees in terms of their distribution. And then, of course, laterally, laterally as well. So here, this is a very interesting block because you can actually, for example, here at the femoral triangle, in this location, you can also block this area and at the same time your saphenous nerve. But here, for example, this is at the adductor canal, you can block the saphenous nerve, the nerve to the vasus medialis, and of course, the sciatic nerve as well. So you can block all three nerves at the same time. So depending on what approach you want, you can also use this. But of course, if you use the subpectineal obturator nerve block, it could cause adductor paralysis. So that is what you need to realize. But if you do it at the level of the saphenous nerve, here at the femoral triangle, there will be no paralysis here and also right here. So no paralysis, only when you do it right above it. Okay, and then of course, as mentioned earlier, you can block the saphenous nerve, the nerve to the vasus medialis, which is actually a branch of the femoral nerve, and the anterior obturator nerve. Okay, now let's go to your genicular nerves. The question is, are they real? There are a lot of people who are just very meticulous about geniculate nerves. They wanted to block those very, very tight nerves. But let me just show you here why you don't need to really do that. Because right here, this is the summary of the geniculate nerve. If you remember what Dr. Jeff Strakowski mentions, he's intrigued by the geniculate nerve because there's just a lot of information and which one is really true. Okay, just to give you an idea, the nerve to the vasus medialis comes from the femoral nerve. The nerve to the vasus lateralis comes from the femoral nerve. Nerve to the vasus intermedius comes from the femoral nerve. Saphenous nerve comes from the femoral. So you have four nerves coming from the femoral nerve. And if you look at this, this is what they say to be the geniculate nerves: the superomedial geniculate nerves, superolateral geniculate nerves, infерomedial geniculate nerves, and of course, this one here, the infrapatellar branch of the saphenous nerve, which is actually the anterior to the knee, also comes from the femoral nerve. So in other words, if you're gonna inject and block these geniculate nerves right here, I might as well just block the femoral nerve in order to block all these nerves here. Am I making sense? And in the obturator nerve, there are two branches, the anterior branch, posterior branch. And as I mentioned, the anterior branch goes to the hip, posterior branch goes to the knee. But look at this. The posterior medial side of the knee is also innervated by the anterior branch. And the posterior is actually innervated by the posterior branch of the obturator nerve. I will tell you later on that this innervation here is only represented in 11% of cases. In other words, it's not always 100%. Although some people would say, I might as well just block it anyway, even if it's only 11%. I might get some relief in doing that. The other thing is sciatic nerve. Look at this. The sciatic nerve has a superior lateral genicular nerve, okay, which innervates the superolateral part, which, by the way, is also innervated by the nerve to the vasus lateralis, which is also superolateral. So if you would like to look into that detail, you will just get confused. The superolateral geniculate nerve is a branch of what? It is a branch of two nerves, a branch of vasus lateralis, which comes from the femoral nerve, and also a branch of the sciatic nerve, which also has its own branch at the superolateral part of the knee capsule. And then, of course, we have your posterior articular nerve at the inferomedial, which is also the same nerve coming from the saphenous. Or should I say, yes. So, in other words, the inferomedial branch comes from two nerves, the saphenous and the sciatic nerve. So you quite see two nerves right there. Then we have your common fibular nerve, inferolateral. Okay, this is the only nerve that goes on that side, and the tibial nerve, which is posterior to the knee. So what I'm saying is, just not to complicate your idea of this genicular late nerve thing, why don't you just go to the main branch, which are the sources of all this? This chart would be very helpful for you. This was published 2019. Okay? So you can use this as reference to say that the reason I'm doing this is because these are just shared nerves by this root. So basically you have only three nerves: femoral, obturator, sciatic. Now let me show you here how these nerves are so complicated in the knee. So many branches, okay, from lateral and medial, coming from both your sciatic nerve and this one here from femoral nerve. This one at the inferior portion coming from the sciatic nerve. So you can just figure out what's going on here. And then of course, this is another way of looking at it, but at least you've seen the original one, this one here, and then this one now here. Okay, so there are really shared branches that makes up the genicular nerve. So you cannot just say, I block what if you block the nerve that is actually innervated by the femoral nerve and not the one by the sciatic nerve? So you don't quite still experience the relief that happens after that, because those are shared branches. Now let's go to your saphenous nerve. This is also a very interesting nerve because this is the longest sensory branch of the femoral nerve, from the lateral aspect of the superficial femoral artery, and then of course into the adductor canal. And there is another motor branch of the posterior division. It travels lateral to the superficial femoral artery within the adductor canal, innervates the vastus medialis. So in other words, this is supposed to be a sensory branch, but there are also motor branch that goes with it. So this one is very important because a lot of times when we see patients, the pain is really anterior. So if the pain is anterior, there is a distal branch of the nerve, which is the infrapatellar branch. If you point it just underneath your patella, then that is just what we talk about, the infrapatellar branch of the saphenous nerve. And you can just block the saphenous nerve proximally at the adductor canal to be able to relieve the pain in this area. And then this is just a complicated ultrasound. I don't want you even to see all the details here because it's just too much information. Now in the Hunter's canal, where the saphenous nerve is, this is also a very interesting part that we need to locate for the saphenous nerve. It's just underneath your vastus medialis. But another thing that I would like to mention, this is not a nerve, but this is an artery that could be compressed at the medial artery. A lot of times, for example, I take the economy class and you tend to flex your knee a lot of times, right? So when you flex your knee a lot of times, the adductor magnus will close the canal and compress the vein here. But if you actually extend it, it opens the canal and release the compression right here. So what we're saying is that when you're flying long-haul flights, you should keep moving your legs, even if you're just in the economy class. So that's why they call it the economy class syndrome. So this is your artery here. This is your saphenous nerve right here. And this is your vastus medialis. Okay, so this is at the Hunter's canal. So again, nothing to see there except that the saphenous nerve is right underneath your sartorius, I would say. I keep saying vastus medialis, sartorius. Okay, another different details of the saphenous nerve. Then at the posterior distal knee, as mentioned, it goes and branch into the different parts of the sciatic nerve. As we can see, the sciatic nerve will split into your posterior tibial nerve and the common peroneal nerve. Common peroneal nerve will winds around the fibula and innervates most of the anterior parts of the leg, and the tibial nerve will continue distally at the posterior part of the knee. So same thing, the saphenous nerve. And then of course the other details of this nerve, you might not want to see that so much information. Okay, so here, so in summary, for the supply of the knee, the obturator nerve, actually they haven't found any terminal branches right there. A research made by Horner and Dillon 1994, 11% of them found the innervation in the knee by the obturator nerve. And then, of course, it's concurred by Macalo 2004. They cannot determine the distal branch of the obturator nerve underneath. But other authors were saying that in spite of the fact that you cannot identify them, you would still continue to block them. You might get some relief. That's what they're saying. Of course, it's the sciatic nerve. So there is a superolateral geniculate nerve for the posterolateral knee pain. So posterolateral knee pain is sciatic nerve. And sometimes, I'm sure you will be able to read this. They wrongly describe the SLGN, superolateral geniculate nerve, as branch of the nerve to the vastus lateralis. We know the branch of nerve to vastus lateralis comes from the femoral nerve, and the common fibular nerve or peroneal nerve is coming from the sciatic nerve. So this is just to correct that. And this is also based on the studies of von Kohe. The second nerve that's coming and innervating that area is the posterior articular nerve. Okay, so this is just the detail. And then of course the femoral nerve as we know it, it has so many branches: the saphenous nerve, nerve to the vastus medialis, nerve to the vastus lateralis, nerve to the vastus intermedius, and it only represents 44% of saphenous nerve having infrapatellar branch. So not all the time the pain right there, the inferior portion, could be attributed to saphenous nerve, only about 44%. And then of course the common peroneal nerve has a recurrent branch that goes into your knee. So here, just some details. So it is possible that if you would like to actually hydrodissect the saphenous nerve, and if you're using a curvilinear probe, you can actually block the saphenous nerve, but at the same time you can block the sciatic nerve in this approach. So it depends upon you. I'm not going to explain the details here, but just for you to see. So the same thing holds true here. From the adductor canal, you go right straight to the saphenous, to the sciatic nerve here, just by approaching this area here. You can also do that for the obturator. So again, the needle track, and then this. So we have mentioned this already as the nerve supply of the knee. And then of course, the variations in geniculate nerve, we have explained this also, that there are just common nerve branches that's both coming from the femoral and the sciatic nerve at the same time. So these are the terminal branches. The saphenous nerve goes all the way to the ankle and actually at the foot. So the saphenous nerve could go all the way down, and you can use your greater saphenous vein as your guide to be able to look for and locate for the saphenous nerve. Now let's go to the sural nerve. Now the sural nerve is also one interesting nerve, and this is formed by the union of the medial sural cutaneous nerve coming from the tibial and the sural communicating branch that's coming from the common peroneal nerve. This is the sensory to the lower posterior lateral calf, ankle, and lateral foot. And this could vary. Look at this. It is also very variable, as you can see it. So there's a lot of variable in the nerves in the lower extremity. So sural nerve, if you scan it, you can start it from the posterior knee between your gastrocnemius lateral and gastrocnemius medial, and right in between would be your sural nerve. So it is located between the two heads of the gastrocnemius. It could course subcutaneously at the posterior lateral aspect of the lower leg, and it is lateral to your Achilles tendon in here, close to your lateral lesser saphenous vein, and it divides into smaller branches that goes into your lateral aspect of the foot, and of course, the fifth toe. And these are just the different variations that you see. I'm just showing it to you just for you to see that there are just a lot of variations. Same holds true with the distal branch. The distal branch of the lateral dorsal cutaneous nerve is also has a lot of variations as well. So the sural nerve here, from proximal between the two heads of the gastrocnemius. Then of course here, this is the lesser saphenous vein at the lateral side, and this is the sural nerve. Remember, the greater saphenous vein is for the nerve, the saphenous nerve below the leg. The lesser saphenous vein is for the sural nerve. And then when you reach the level of the ankle, posterior to your ankle at the peroneal muscles, and between your this muscle, the extensor digitorum longus, you have the sural nerve right here. So let's go to your common peroneal nerve. So as we see, it is coming also from the sciatic nerve, and then it has a deep branch and a superficial branch. And then of course, it goes all the way down, and then when it reaches the foot, the superficial peroneal nerve give off two branches, the intermediate dorsal cutaneous, as you can see here, just above your ankle, okay? It divides into two branches, the intermediate dorsal cutaneous, and of course the medial branch. And then as it reaches the foot, from this level up to the foot, these are the two branches. It splits just below or above what is called your just above, I should say, the talar dome. And then as you go down, you can also see that the deep peroneal nerve could also have a lot of variation. So let's say here, this is at the anterior interosseous membrane, and then the deep peroneal nerve is just sitting above it. And then as you go down underneath the extensor digitorum longus, you can see the deep peroneal nerve side by side with your dorsalis pedis. And then as you go down, you can see the deep peroneal nerve still at this level underneath this muscle. And here, you can see that this also will split into two branches. And we can identify this from the artery here, the dorsalis pedis at this level, at the ankle, at the dorsal ankle, and then it splits into two branches. The dorsal will splits into the medial branch, and then it becomes your branch here just below your dorsalis pedis, right at the metatarsal area. So at the metatarsal area, we can now see two branches, and then eventually at the distal part, it will converge again. So it splits and then converge. Now let me show you what really happens here. So this will give rise to a condition that is called the anterior tarsal tunnel syndrome. I will explain that to you a little later. But right here, just for your illustration, so the deep peroneal nerve will go down all the way, but at the level of your I should say, the cuneiform and the metatarsal bone right here between the cuneiform 1 and 2, the tarsometatarsal joint, it splits into two branches, and then eventually it will converge again. This way at the M1 and M2. But the thing is, there are times when we thought it's an arthritis right here. You can actually palpate it. It's what they call the Lisfranc joint. And here, even as we think this could be actually an arthritis, it is possible that we are actually compressing the deep peroneal nerve. This is what they call the anterior tarsal tunnel syndrome. Now, this anterior tunnel syndrome will give rise to either a pure sensory or a pure motor. Now, if it is a pure sensory, then it could be the medial branch of the deep peroneal nerve. So the medial branch. If there is a combination of motor, which means the extensor digitorum brevis is also affected, then it could affect this part here, the lateral branch. So the medial branch, the lateral branch. So depending on which area is compressed, it will give rise to what we call the anterior tarsal tunnel syndrome. So this is another illustration of that split. And then, of course, the lateral branch of the deep peroneal nerve could also be secondarily affected. And this could also be misconstrued as lateral ankle sprain, but this could also be a compression of the lateral branch of the deep peroneal nerve. So how do you check? You have to invert and plantar flex the foot. And when that area is stretched, there is pain in that area as well. So just the illustration ultrasound of where the deep peroneal nerve is located in relation to the other structures. Now let's go to your deep posterior nerve. Okay, so this is the posterior branch of your sciatic nerve, and it is also found between the two heads of your gastrocs, and then it goes all the way down until it reaches actually the foot. As you can see, there are different variations as well. We will not discuss that anymore, but this is the highlight of the posterior tibial nerve because this is where the entrapment happens at the ankle. And we call this the tarsal tunnel syndrome. In the tarsal tunnel syndrome, the tibial nerve will actually gives off three branches. We have your medial calcaneal branch that goes posteriorly going to the heel. We have your medial plantar nerve that goes into your 1.5 of your foot or the sole of the foot, and the lateral plantar nerve that goes into your lateral 3.5. Now, just for your information, the lateral plantar nerve will give off two branches. We have your inferior calcaneal nerve, which we call the Baxter's nerve, and we have also the what we call the hallopus nerve, which is the other branch of the lateral plantar nerve. Okay, we will discuss that a little bit. So this is the trifurcation, and then right here, the medial calcaneal nerve is the one that gives most of the sensory, 64% at the heel pad. So if you are having a patient that complains of pain at the heel, the first thing that you should always check is the nerve. Now, the medial calcaneal nerve could be above the tarsal tunnel or could be inside the tarsal tunnel. But it is important to realize that this branch here, which is the medial calcaneal nerve, goes all the way to the heel in 64% of the time. Then, of course, the lateral plantar nerve, which gives rise to the inferior calcaneal nerves, which we also call the Baxter's nerve, will also give branch in about 81%, and this also could give pain at the heel itself, very close to the anterior portion of the calcaneus. So depending where the location is, if it is more posterior, then you can say that it could be entrapped by the medial calcaneal nerve branch. If it's more anterior, you can say that it could be compressed by the inferior calcaneal nerve branch of the lateral plantar nerve. So just for your illustration, this area is medial calcaneal nerve. So you can see it right here. This one is your lateral plantar nerve, where the Baxter's nerve is originating. This is your medial plantar nerve, and this is your saphenous nerve. This is your sural nerve. So you can see the dermatomal distribution of those nerves just for you to find out exactly where you need to examine the patient to see which nerves is compressed. So this is the tarsal tunnel, of course, the posterior tibialis, flexor digitorum, and then of course flexor hallucis right here. The posterior tibial nerve is right there. So this is the long axis view. And then of course there's also a lot of variations as well. But the more important thing is if there is pain when you jog, what's called a jogger's heel, then this is the entrapment of the medial calcaneal nerve, which is a branch, direct branch of your posterior tibial nerve. So this is another different variations, the medial calcaneal branches. So there's just a lot of variations here. And then of course, the Baxter's nerves or the inferior calcaneal branch. What I was saying a while ago is if it is more anterior, this is the location of the Baxter's nerve right here. Okay, so this is anterior. But if it is more posterior, then that is your medial calcaneal branch. Now, for those of you who are doing injection, this is one challenging area where you have a hard time trying to hydrodissect. As we said, most of the pain in the heel is initially nerve. Don't think about the calcaneal spur or things like that. It's nerve at the very beginning. In fact, 88% of heel pain is due to tarsal tunnel syndrome. So you would like to hydrodissect. So which is the safe zone for hydrodissecting? Thanks to Dr. Son in the research, now they divided these parts from the inferior pole of your medial malleolus up to the tip of the calcaneus right here, divided into segments 1, 2, 3, 4, 5. Then you need to inject. This is the zone that is safe for tarsal tunnel. So if you put your probe here, this is the area where you need to inject because you will not puncture any neurovascular area in this area. In other words, most of the vascular is right here, and this area is where the nerve is. So that is a safe zone for injection. Now, this one is just an illustration of how the nerves will weave through your foot from the posterior tibial nerve. And then this is another one with the entrapment site of the Baxter's nerve. And there are actually two sites, the entrapment site. It could be entrapped at the lower calcaneal tube between your abductor hallucis fascia and the quadratus plantae, just immediately after it actually branched out from the inferior calcaneal nerve. And the distal branch is the one that I've shown you a while ago at the front part of the calcaneum, which cause pain anterior to your heel. And this is also another location. This is the proximal entrapment. And this is how you can approach the Baxter's nerve if you wanted to inject at the proximal entrapment. And then, of course, this is also the course of these two nerves from 1, 2, 3, and 4. Look at the M and the L, the medial plantar and the lateral plantar, how they course through your structures until it reaches the most distal part of the foot. Then, of course, that's the lateral, that's the plantar nerves, and this is actually at the medial foot that is formed by your flexor digitorum longus and flexor hallucis longus. They converge as tendons, and then sometimes compress a nerve there. The nerve that is compressed is most likely the medial plantar nerve. So just remember that. And then, of course, this could also converge at the third web space, where you also will give rise to your Morton's neuroma, because two nerves at this area becomes a little bigger. And just for your information, when you are trying to scan, if you are putting it, this is your plantar, this is your dorsal. So let's say this is where you put your probe here. the first thing that you see is the intermittent, the bursa first, then the ligament, and then the nerve. But if you look at it from the plantar side, you will see the nerve first, then the ligament, then the bursa. So that's the sequence of how the structures are being formed. And then, of course, we have one last nerve here. After the Morton's neuroma, it is also possible that the medial plantar nerve could be entrapped right here at the medial side of the big toe. This is what we call the medial proper plantar digital nerve. If you also entrap this, it will give rise to what we call the Joplin's neuroma. So you can also injure that if you're going to inject that side, especially if you're trying to remove some painful gout or podagra in that area. So be careful with these nerves because that is the medial plantar nerve branch. So thank you very much for your time. I think I lectured too long. This is such a very long lecture. So
Yes, Dr.
I
Yes,
just
Dr. Jim. Can you hear us? Thank you very much for your great lecture. It was very in-depth. And there were so many nerves that you discussed today. And we'll just check if there are any questions from the audience or from those our attendees tonight. So while we're waiting for their question, I have a question, Dr. Jim. May I ask?
sure, Pash.
Okay, Dr. Jim, so again, thank you very much for that lecture. Regarding the runner's heel that you described earlier, you showed us about the location of the proximal versus the distal branch that's also safe to inject. However, for those with, yes, the Baxter's nerve, Dr. Jim. So if we were going to choose between the proximal and the distal branch, which one do you usually inject first? If you choose, because I feel that the distal branch may be more painful for the patient since it's more sensitive area. Which one do you inject first?
I would usually inject the more proximal one. In fact, sometimes if I'm not really sure about the distribution of pain of the patient, I would usually inject the posterior tibial nerve, to be honest. And then if I really am sure that I'm dealing with either a medial or lateral plantar nerve, then I would inject each nerve separately. But if the complaint is heel, I would approach the medial calcaneal nerve branch. Remember, the medial calcaneal nerve branch is very proximal. It's sometimes it is found outside the tarsal tunnel. It doesn't really go inside the tunnel. Sometimes there are variations that you can see it inside the tarsal tunnel, and that is the first one that splits prior to the splitting of the medial and lateral plantar. Now, if I am dealing with a more anterior portion of the heel, because you can see it, actually, you can actually palpate it by physical examination where the pain really is. And the patient will sometimes point, oh, it's more anterior. Then I would say that it's the Baxter's nerve. But if it is more posterior, then I would go for the medial calcaneal nerve branch. That way,
Okay.
you know, it's
Thank you, Dr.
88% of the heel pain is nerve, not calcaneal spur.
Yes, that was also one of the considerations because it might be a spur, correct? So at least we should scan that area also to make sure that it's a nerve involvement.
Yes,
For the, I think, yeah, maybe one more question, Dr. Jim. Are we allowed to ask one more?
Yeah, sure.
Dr. Jim.
Dr. Domingo, yeah.
Okay lang ba, Doc, if I ask
Dr. Jojo is to ask.
Akala ko tutulungan mo ako mag-explain.
If it's okay with you, Dr. Jim, I would like to first congratulate you for a very well researched presentation. You've cited more papers than I can actually swallow in more than an hour's lecture. But if I were to do a procedure for plantar fasciitis, Dr. Jim. What nerve will I block? What nerve would you suggest that we block, Dr. Jim? Thank you.
Ang sagot dun, Joe. You know the answer, Joe? Usually, okay, just to answer the question of Dr. Jojo, Dr. Jojo knows the answer. He's just asking the question. Um, I would go very proximal, actually. I would, as I've said, I would go hydrodissect the posterior tibial nerve because sometimes if the distribution is very diffuse, it's very hard to distinguish which one. But if the patient can pinpoint really, because sometimes the ultrasound might just show a very swollen plantar fascia, and then I would kind of see that to be coming from the medial calcaneal nerve. If I can hydrodissect that particular nerve alone without actually hydrodissecting the medial plantar and lateral plantar, I would prefer that nerve, the medial calcaneal, because that's the first branch that you can see that's splitting. Remember, when you go up and down, you can see there is a nerve that splits. The first one that splits is the medial calcaneal nerve. So you can actually target that first. And then if it doesn't get you a good relief, then I would go very specific to the proximal Baxter's nerve, which is actually between your abductor hallucis and flexor digitorum brevis. It's very the location is just right uh, after it splits from the from the lateral plantar nerve. Yung exactly after the separation, then you can already hydrodissect that. That is because if you hydrodissect the distal part, of course, the one we learned, remember, Joe, we learned something before, I don't want to mention, but we learned before that we have to inject the Baxter's nerve right very close to the distal calcaneus, right? But that is already distal branch. It's useless to block that. Why will I even block that if it's distal? It innervates, it innervates only that part. But if I block it more proximally, then I would be able to remove the pain, including the plantar fascia. But if it is just plantar fascia, I would probably just block the medial calcaneal branch first.
Excellent answer, Dr. Jim De Castro. Thank you so much, sir. Very practical clinical pearls. Thank you for sharing that, Dr. Jim. Thank you.
Dr. Jojo, you know the answer to that question. Thank you, Joe. Okay.
Thank you, Dr. Jojo. Okay, Dr. Jim, maybe one last question. About the, yeah, you said, you mentioned earlier about the femoral triangle, correct? That it's a little bit safer in terms of you don't get any paralysis if you try to inject in that area rather than the subpectineal area when you're trying to target the obturator nerve. Did we get that right, Dr. Jim?
Yes. Actually, you inject two nerves right there. You inject
Yes.
the obturator and the saphenous at the same time
Yes.
at the femoral triangle. But
Yes, Dr. Jim. So it's more beneficial.
yes, that's more beneficial because there's no paralysis. But sometimes
Yes.
anesthesiologists would go very proximal, but realize that when you go proximal, you also paralyze the entire adductor muscles. That is at the subpectineal.
Yeah, Doc. So my question actually is,
Okay, what is your question?
yeah, my question actually, Dr. Jim, is how do we position the patient? Because I saw in the earlier slide that it was pointing just that anterior. The patient was lying on the just anterior, the same supine
Which one?
position. Do we externally rotate it a little bit?
The
The
subpectineal
leg, the
or the
leg of
femoral
the
triangle?
patient to expose. No, for the femoral triangle.
Oh, that's easy because you just draw a line. You saw the line, and then
Yeah.
it's actually very close to the adductor canal. Just a little above it is the femoral triangle. Very very easy because it's just on the medial side. But if you're referring to the subpectineal, you have to really go very proximal and you have to go right very close to, if it's a lady, very hard to ask him to to externally
Yeah,
reach out.
I saw the image. Yes, we saw the image, and it was very interesting indeed if you were to position the patient that way. So anyway, Dr. Jim, I think there are no more questions in the.
I was,
I don't see any more questions. I think everybody.
oh, Jeremy is raising his hand. Maybe he's going to give us ice
Oh,
cream.
okay, Jeremy. Jeremy, you have a question?
Oh, hello. No question. Just want to congratulate Doc for a wonderful lecture.
Okay, thank you, Jem. Actually, I was expecting you to ask about the geniculate nerve. You know, this is very interesting. I think the very important part in this lecture is the geniculate, really. That's why I put it at the center, because there's just a lot of confusion there. But the first graph is very helpful because there is a lot of overlap, and sometimes we think we're blocking it right. But remember, there is also always a distribution that's coming from both the sciatic and the femoral nerve all the time. So it's very important for me, looking at the studies, I would go to the root. I would go to just the femoral nerve, the sciatic, and the obturator nerve, just not to cause any complication. Why would you go to the geniculate nerve where there is an overlap of all this distribution? You can block one, but still you will think, oh, I'm just blocking the femoral nerve, but there is also an overlap of the sciatic nerve. So it's just a waste of time trying to figure out which one. But just that's that for my information. And then very interestingly, of course, is the other technique where you have to block both the saphenous and the sciatic nerve at the same time. Thank you very much. And,
Yes, Dr. Jim, and I'm sure that a lot of us right now who watch this will be reviewing your lecture again over at YouTube, correct? You will be posting this again at YouTube so we can review the lecture again.
Yes, of course. Jojo, thank you very much. Jojo, do you have any correction from what I told you?
Excellent lecture, Dr. Jim. I couldn't have done it better myself. Congratulations, Dr. Jim.
Kala ko, i-correct mo ako, Jo. How about you, Pash? Do you have any correction?
No, I need to review this lecture again. I never get tired of watching your lectures. Always something new to learn. Thank you, Dr. Jim.
Thank you.
And thank you to all our attendees tonight.
You know, this is the first time
So God bless everybody.
God bless everybody. Good night.